I would like to present this question, saying in hypertrophic cardiomyopathy, a maximum provoked peak of more than 35 millimeters, 40, 50, or 60 leads our therapeutic strategy. Okay? So, which one is the maximum provoked peak gradient for base our therapeutic strategy? So I think we could start voting from now. So that was, okay, that was the correct answer. Indeed, 50 millimeters is the number and above that is the crucial number to base our therapeutic strategy in patients with a hypertrophic cardiomyopathy. I'm talking about gradient, correct? Outflow tract gradient. Okay, may I have the next question? Okay, now we started going on. In patients with hypertrophic cardiomyopathy, ICD, implanted defibrillator, correct, is indicated if the estimated risk, according to the new tool published very recently and announced in our Congress in Barcelona, our new guidelines, I'm going to speak now. So what is the number above of we decide to implant an ICD according to the new calculation algorithm? It is 3% calculated annual possibility for sudden cardiac death is 4. This number represents the annual rate, the annual possibility for sudden cardiac death development. Is 4, is 5, or 6? Please vote. As you know, we have now a new calculator, a new tool, more reliable than the previous one. And this number represents the annual possibility of sudden cardiac death. It's not correct. It is 6, the correct number. So according to the new guidelines, if finally you have calculated the annual possibility of sudden cardiac death 6 or more, you have to implant. But, however, 5 is not mistake. Between 4 to 6, you have to decide. Is borderline. Okay? Below 4, you should not. Next. Perioperative transesophageal echocardiography is class who? Recommendation for patients undergoing septal myectomy. Class 1C, Class 2A-B, Class 2A-A, or Class 2B-C. Perioperative transesophageal echocardiography is Class 1 recommendation for patients undergoing septal myectomy. Indeed, you are correct. The majority is correct. It is class 1, level of hepatitis C indication. Great. And now allow me to start my presentation. May I have the first slide, please? I thought I should start in this way because it is already about 6 months' time since the new guidelines have been published. So I would like to have your feedback. And now let's start my presentation. Okay, great. Let's start. These are my disclosures according to the rules. So, as I said, very recently we had the opportunity to publish our new guidelines about hypertrophic cardiomyopathy. I would like to highlight here that these guidelines related to hypertrophic cardiomyopathy are the first guidelines coming out from the European Society of Cardiology focused on this topic. This is important. And as you know, this entity is a rather common entity, and of course, we should have a number of well-organized trials to calculate therapeutic and diagnostic techniques. For a number of reasons, unfortunately, we have not. So, mostly, these guidelines are based on observational cohort studies and expert consensus opinion. We had not so many clinical trials, well-organized, randomized trials to base our recommendations. Through these guidelines, the aim is to provide to the healthcare professionals a well-organized, practical, diagnostic, and treatment framework for all the patients of all ages. Let's start from the basics. Hypertrophic cardiomyopathy is, of course, defined by the presence of an increased left ventricular wall thickness, which cannot be explained as a secondary result due to a certain reason. In other words, the increased left ventricular wall thickness is of unknown or not well-known origin. And here, you have the opportunity to see the main reasons, the main etiologies behind this left ventricular wall thickness increase. It is a sarcomeric protein gene mutation in a percentage between 40 to 60%. It is unknown to us, the origin, to a percentage around 30%, and there are some other genetic and non-genetic causes that could lead to this dysfunction, to this abnormality. Let's see in brief the pathophysiology of hypertrophic cardiomyopathy. We have, of course, left ventricular outflow obstruction, very well-known problem. We have also in these patients, in many of these patients, a degree of mitral regurgitation, diastolic dysfunction, and myocardial ischemia. And very often problem is, of course, the development of atrial arrhythmias or ventricular arrhythmias, like atrial fibrillation, especially because the diastolic dysfunction. What about the diagnostic evaluation? We use three main weapons here. It is the ECG, it is imaging, different kind and modalities of imaging, and to some degree we are using genetic testing and family screening. First is the classical methodology, the classical tool, the ECG. And we know that the standard 12-lead ECG can be either normal or abnormal in these patients with hypertrophic cardiomyopathy. Can be normal to some degree in around 6% of these patients, which this number is not small. Please keep in mind that according to the different cohort analysis and registries, a percentage of around 6% of the patients present with a normal ECG. In the field of echocardiography, we are using 2D echocardiography, Doppler studies, provocative exercise testing. We have used the contrast echo techniques, and we have to discuss a little bit about the transesophageal echo and its role. Talking about echocardiography, here is an important algorithm included in our guidelines about the use of 2D and Doppler echocardiography at rest, or using these techniques during the Valsalva maneuver and study. So, as I said at the beginning, we have to separate the patients. Those patients with a left ventricular outflow tract pressure gradient of more than 50 millimeters of mercury, and those with less than 50. This is the main classification according to the guideline. So that's why I had presented this question to you, because the number 50 is very important for your decisions. And algorithmically, then you can take some decisions according to symptoms. If the patient is symptomatic or the patient is asymptomatic. The worst scenario is, of course, if the patient has a gradient of more than 50 millimeters of mercury and being symptomatic. And of course, you have to take a decision here. What the patient needs. A myectomy, another operation, a device. What is new in the 2D echo according to our guidelines and according to the existing trials? Myocardial deformation parameters are often reduced in these patients, despite, in some cases, a normal injection fraction. So, please, in those patients who should be evaluated properly, please use strain analysis, tissue tracking, and septal tracking. Also, we could use intracoronary contrast echocardiography. And indeed, this technique is recommended as 1B indication for those patients possibly undergoing a myectomy, and especially alcohol ablation. So, if you like to make a proper job, in the case that you have selected the alcohol ablation as the technique for myectomy, as the technique of your priority, in this case, you have to use intracoronary contrast echocardiography to ensure the correct localization of the thickness and where the alcohol should be used in order to be effective. And of course, on this slide, on the right side, you have the opportunity to see where the contrast is mostly accumulated. It is, yeah, but they have, okay, great. So you have the opportunity to see here where the contrast is accumulated, and here we have now clear understanding where the ablation, the alcohol ablation, should work and should be focused. Great. What about transesophageal echo? As I said, perioperative transesophageal echo is recommended in patients undergoing septal myectomy to confirm the mechanism of the increased gradient and the obstruction. And so, if you have a better understanding about the left ventricular outflow tract obstruction, you have the opportunity to guide the surgical strategy and to enjoy a better result. What about cardiac MRI? Unfortunately, I have not the time now to be very specific, but as you have the opportunity to see here, there are different categories of patients and cases, and how accordingly you have to use the cardiac MRI. For example, in the absence of contraindications, CMR with late enhancement gadolinium is recommended in patients with suspected hypertrophic cardiomyopathy who have inadequate echocardiographic windows in order to confirm the diagnosis. And here the indication is 1B. It is very interesting that these guidelines, our new guidelines, are very clear. If somebody likes to study these guidelines and to go through, he or she has the opportunity to recognize different categories analytically. In the absence of contraindications, CMR with late enhancement gadolinium is recommended in patients with suspected hypertrophic cardiomyopathy who have inadequate windows. So if you have this problem, go please to another technique the guidelines indicate. Similarly, we have some other indications for some different cases. Anybody here, I'm sure, is pondering about the role of the genetic testing. When, who, and how. Again here, our guidelines have developed a special algorithm. So, you have to study this algorithm and to understand when, to whom, and how you have to use this technique. The genetic testing is not for all the patients. So, if you believe that there is a mutation, it's different, and if you believe that there's not any mutation, the algorithmic cascade is a different one. What about the clinical assessment of different symptoms? In these patients with hypertrophic cardiomyopathy, it's quite often the patients to be complained about chest pain or heart failure. And myocardial ischemia is well known that is developed due to microvascular dysfunction, increased left ventricular wall stress, and left ventricular outflow tract obstruction. Again here, our guidelines are saying that yes, you have the right, you have the obligation even to ask your patient to be tested using CT coronary angiography if this patient fulfills certain criteria. But for sure, these two categories of symptoms are very important: chest pain and heart failure, and in many cases you have to continue and to fulfill all the spectrum of diagnostic analysis. Finally, talking again about clinical assessment and symptoms, you have to remember that chest pain and heart failure is not only a result of hypertrophic cardiomyopathy. So please make your best in your diagnostic analysis to differentiate if these symptoms is because they hypertrophic cardiomyopathy or if something else is behind, like an increased atherosclerosis in the case of the stent pain, of the chest pain. As the time is very short, I would like to say a few things about syncope and sudden cardiac death. No doubt, syncope is one of the, let's say, dangerous manifestations in patients with hypertrophic cardiomyopathy. Nobody likes to risk a patient with hypertrophic cardiomyopathy and syncope or near syncope, but instead we have to make a very analytical effort to evaluate the reasons of syncope and to decide if the patient should be covered by an ICD. As unexplained non-vasovagal syncope is a risk factor for sudden cardiac death, particularly when it occurs in young patients in close proximity to their first evaluation, treatment with a prophylactic ICD may be appropriate in individuals with other features indicative of an increase of high risk for sudden cardiac death. We have to evaluate the persons with syncope looking very clearly and very analytically and carefully about the obstruction and the size of the obstruction. How much obstructive the disease is. Do we have any possibility to use any drug for this problem? Is any possibility atrial tachyarrhythmias to be behind the development of syncope? And of course, what is the possibility for a sudden cardiac death development? Our guidelines are analytically referred to different drugs. We could use non-vasodilating beta blockers, verapamil as class 1 level of evidence B, and consequently we could use other drugs like verapamil, as I said, the TSM-2A, disopyramide, low dose of diuretics, or different beta blockers, even intravenously. In very brief, I would like to speak about the two myectomies, the surgical septal myectomy and the septal alcohol ablation. Both are indicated in our guidelines. What about dual chamber pacemakers? It is interesting. None of these techniques are indicated as class 1 or 2A. It is 2B indication for certain groups of symptomatic patients. Certain groups of symptomatic patients. What about thromboembolic prophylaxis in patients with atrial tachyarrhythmias and hypertrophic cardiomyopathy?
Doctor, your time is up.
Can I have one? Yeah, great. Please forget the Charles-Bass score. Here you have to be more aggressive is the message. So in patients with paroxysmal or permanent atrial tachyarrhythmias, please use either warfarin or the new anticoagulants, but please forget the Charles-Bass score. What about amiodarone for atrial fibrillation treatment? Yes, is the main antiarrhythmic if you have some difficult cases. And I'm closing this presentation with the most important calculation in these guidelines, the calculation about sudden cardiac death. In the past, as you know, we are using a different algorithm to decide about the use of ICD or not. And I like to remind you that, of course, if somebody had a cardiac arrest, should receive an ICD as a secondary prevention. If somebody has a history, a family history of sudden cardiac death, it was strong indication to receive an ICD. If somebody has had non-sustained VT or abnormal blood pressure response, we had to judge about the ICD. And now we have a new calculator in our guidelines. And this calculator is based on certain parameters: age, family history of sudden cardiac death, left atrial diameter, maximal left ventricular wall thickness, maximal left ventricular outflow tract gradient, non-sustained ventricular tachycardia, and unexplained syncope. And each of these parameters takes some points according to this calculator. Now, this is an example. I don't like to spend time, but this calculation, one by one, had led to this number. Okay? If the number that you conclude is more than 6, as I said before, you have to use ICD. I have to stop here. Actually, that was my last slide. I would like to stop here saying, please follow these clear guidelines for the best of your therapeutic and diagnostic policy and for the good of your patients. Thank you very much indeed.
Dr. Panos, can we have a question before after your talk, because this is completely different from the talk of Dr. Fusto. Yeah, we have 10 minutes for discussion. Okay. When you want to have a question, you come to the mic, please. اللي عايز يسأل يا جماعة يقف قدام المايك.
Thanks, Dr. Panos, for this elegant talk. I want to ask about the definition of hypertrophic cardiomyopathy. Your definition in the first slide is significant electrical obstruction, as obstruction plus hypertrophy without any